faster, because in the presence of a physician, a patient should not be allowed to not breathe when a physician is present. So a respiratory arrest, the cessation of breathing, that is assumed to not have occurred in a witnessed arrest when a physician is present. So the therapy that was directed towards Michael Jackson was therapy towards a cardiac event that was unclear. And the fact that this was a respiratory arrest and that it was caused by sedatives, and specifically by propofol, was withheld. So that neither the paramedics nor the physicians at UCLA knew what they were treating. A patient comes in an arrest, you have only seconds to go down a treatment path one way or the other. They were not given the information to choose a treatment path appropriate for what had happened. That information was withheld.
And from a medical standpoint, because the assumption based on Conrad Murray's statements would be that it was an almost instantaneous, you're observing the person goes down as a result of a cardiac arrest.
Correct.
And if your assumption is that the person went down immediately as a result of a cardiac arrest, that dictates what subsequent treatment may be.
That is correct.
What is a doctor's obligation in a type of scenario where the doctor is present when the injury befalls the patient and then the patient's care is transferred to another doctor? What is the doctor's professional, ethical, and moral obligation in that scenario?
To tell the truth. I can't put it simpler than that. The doctor is obliged to tell the truth, the whole truth, and nothing but the truth. You know, the doctor has to say, this is what happened, and this is everything I know that may help you to save this patient's life. Anything less than the truth, the whole truth, is inexcusable.
And is this also then both an egregious and ethically unconscionable violation of the standard of care?
Absolutely. Again, the doctor-patient relationship is built on trust. It's built on the patient's interest always being ahead of the doctor's interests. When information is withheld, you violate that trust. When information is withheld from the people trying to save the life of your patient, you have violated that trust in ways that are so foreign to me, I truly have trouble even conceiving of it. Patients have a right to
Okay, the objection is sustained.
Okay, I'm sorry.
That's all right. Everything with patients thereafter is stricken. The first part of the answer is in evidence, ladies and gentlemen. Mr. Walden.
And in regard to what you're about to say, when a patient is in that situation and you expect a doctor to act in accordance with that bond of trust, what are the patient's rights in that situation?
The patient has the right to expect the doctor to be honest. Patients have a right to expect the doctors to be honest and place their interests, there being the patient's interests, ahead of the doctor's interests.
What is polypharmacy?
Polypharmacy is administering many drugs at once. Poly meaning many, and pharmacy referring again to drugs.
And in this case, from Conrad Murray's own words, you're aware that he administered diazepam or a Valium?
Yes.
As well as midazolam,
yes.
lorazepam,
yes.
and propofol?
Yes.
Is that polypharmacy?
Absolutely.
and how would you characterize that treatment?
I would characterize it as saying it doesn't make any sense. The reason I would characterize it that way is that lorazepam and midazolam are very similar drugs, and from the perspective of the brain, they're nearly identical. These molecules bind exactly the same, it's called a receptor, exactly the same thing in the brain. One just replaces the other, and do exactly the same thing in the brain. The only difference is how long they hang around for. That's part of the pharmacokinetics. How long they hang along. That's the only difference. I don't understand any rationale for switching between midazolam and lorazepam in a patient who you're having trouble having them fall asleep. Because they're binding the same place. The therapy that was used doesn't suggest any understanding of these drugs. Additionally, they're being given along with propofol. Now that's common. We commonly combine a drug like midazolam with propofol in anesthesia. But we do it in ways that we understand. We don't willy-nilly, let's give a little more lorazepam, let's give a little more midazolam, let's try some more Valium, let's do this. The polypharmacy in this case suggests that it was done without any real understanding of the drugs that were being used, how they worked, and how they interacted.
And was that, in and of itself, another serious violation of the standard of care?
Yes, that was a serious violation.
Now, assuming, again, from Conrad Murray's own words, that the midazolam, lorazepam was given, and then just the 25 milligrams of propofol was given, would you consider that a safe dose of propofol in this setting as you've described?
Not at all.
Please elaborate.
In this setting, there are so many variables that make it impossible to predict the response to a dose of propofol that there is no safe dose. Midazolam has been given and lorazepam has been given. It would take me a couple days to try to figure out with the models that I have what the effect of that would be. It's not clear. I could calculate it, but it would take time. Then you have a patient who may be withdrawing from benzodiazepines, from Valium-like drugs. After all, this patient's been getting them every night for 80 days and may have withdrawal from them, or may have tolerance to them. We don't know. Could the patient have tolerance to propofol? It's not well documented because nobody does this. But we do know that to all the other drugs that act at that location, it's called the GABA receptor, all the other drugs that act there are associated with dependence and symptoms of withdrawal. So maybe the patient is dependent on it. Maybe the patient may have withdrawal from it. We are in pharmacological never-never land here, something that's only been done to Michael Jackson and to no one else in history, to the best of my knowledge. So any dose of propofol is a potentially dangerous dose.
Dr. Shafer, I want to question you about a experimental research paper from China regarding propofol and insomnia. And I want to get your perspective as an editor of an anesthesia journal. Do you know to which article I'm referring?
Yes, I have it with me.
And that is the article entitled Propofol-Induced Sleep Efficacy and Safety in Patients with Refractory Chronic Primary Insomnia, and published after Michael Jackson's death in November 25th, 2010, online?
Yes.
As an editor of one of the leading anesthesia journals publications, let me ask you, did you evaluate this research paper?
Yes.
Independent or as a result of your work on this case?
As a result of my work on this case.
And at the time that Conrad Murray was giving Michael Jackson propofol every night for a period of months, was there any literature that set the precedence that propofol was appropriate for the treatment of insomnia in this type of setting, or in any setting?
There was no such literature, and I can support that with numbers if you like.
You actually investigated and did research to see if there are any publications that have been subject to peer review?
Yes.
And you found none?
There are. The direct answer to your question is no, I found none.
What are the specific numbers that you found?
There are, this is actually just recent, but there are over 13,000 papers in the medical literature about propofol. There are over 2,500 papers in the medical literature about propofol sedation. This is found using something from the National Library of Medicine that every doctor and every researcher knows, called PubMed. 2,500 articles about propofol and sedation. If you ask for articles on propofol and insomnia, you get one article. That's it, just one article. And it's the article that I'm holding. There's only one paper, and it's this one, in the entire world's medical literature on propofol and insomnia.
And in your opinion, was the treatment, alleged treatment of insomnia by use of propofol, an independent, egregious violation of the standard of care?
Absolutely.
And as far as this actual publication, can you describe, are you familiar with the basic purported research or experiment that was put forth in that publication?
Yes, I've read this several times.
And where did that experiment take place?
The experiment took place in China at the 3rd Military Medical University in Zhangjiang, in the People's Republic of China.
And as an editor of the Anesthesia and Analgesia publication, did you review this article critically as you might any other submission for publication?
Yes, I did.
And what conclusions did you draw?
This is a paper that certainly we would not have accepted for publication, and in fact I probably would not have even forwarded it to our editorial board for consideration, but would have rejected on submission. There are a number of red flags in the paper. The top of the list is it talks about the use of propofol for sedation, but it doesn't give the dose of propofol. It doesn't tell you how much propofol was used, which is a red flag that there's a problem. The next thing is that extraordinary claims require extraordinary proof. It's a fundamental concept when you look at the medical literature. The more extraordinary the claim, the more evidence you need to support that claim. This article claims that after 5 days of just getting a 2-hour infusion of propofol, 6 months later, the subjects who got propofol were still much improved in their sleep pattern. It could be true. It could be true, but it's an extraordinary claim which is supported by 64 patients. The evidence is not adequate for the claim. Lastly, the paper